I've rarely seen the most severely affected because it's not ethical to ask people who are so ill to take part in a study when life's already full of so many different challenges and the risk of symptom exacerbation is significant. So people with severe ME are often alienated from primary care services. They'll tell me that years ago they used to go to the GP, but the GP really didn't think there was much wrong with them, couldn't help them, didn't really want to follow up with them. We all as healthcare professionals prefer to see people improve and get better, and it's very disheartening when there's so little you can do and when you can't actually even confirm a diagnosis. From my point of view, they're quite wary of engaging in research, particularly following the PACE trial, which was an iniquitous trial that took place in England. People with severe ME/CFS do require home visits in the main. NICE recommends annual visits. And they're often socially disconnected, so it isn't just the medical services they're apart from. In the beginning, I used to ask people with severe ME/CFS if they had a relative or a friend who could be a healthy control for them. And no, they were alienated from their friends. They visited once or twice and then they got bored and there was nothing to say. And then their family don't believe there's anything wrong with them, so they don't see anything of their family. So the only person in their lives is sometimes the healthcare worker who comes in to give them care. So at QME at the LSHTM, we actually use the SF36 to capture health-related quality of life, and it's very widely used in ME/CFS. So looking at this spidergram, if you look, these are the various symptoms that people have that are captured by the SF36, and some of them are to do with mental health and some of them to do with physical health. And if you look at the physical health components, they all begin with PF. You will see that basically people are hugely impacted. If you look at the physical component summary, which is up there on the left, and look at the red, which is the people with ME, not even with severe ME, you'll see that they're much more impacted than people with MS, and certainly a long way away from our healthy controls. And as you can imagine, people with severe ME are even further impacted. However, if you look at the mental health scores, which are just below the physical component summary, you'll see that they're not so distant. So these aren't people who are profoundly depressed. Staying in bed, being confined to bed, and having no friends and family, of course, impacts your mental health and of course causes depression. But I used to do a lot of work in mental health, and if I said to someone with depression, oh, look, you used to climb mountains, would you like to do that again? Don't even talk to me about that, someone with depression will say. When I say to someone with ME/CFS, oh, look, there's a photo of you on Mount Kilimanjaro. Oh, if only my body would let me do that, I would love to climb Mount Kilimanjaro all over again. So it's a very different type of mental response to this disease. These are longitudinal results from the study. So remember, we visited some of these participants at up to 7 time points, and we've put the whole lot together and looked at it. And again, if you look, slightly confusingly, we've got the most severely affected in the middle here, and you can see that they are most affected. But if you look again at the mental component score at the top, they're actually not very much affected. However, if you look at the GCS7, and the GCS7 is scores put together. So this is all the symptoms that we associate with ME: pain, sleep, immunological response, post-exertional symptom exacerbation, autonomic symptoms. You can see just how severely physically affected over a long period of time people with ME are. And not everyone experiences pain, but when it's there, it can be a constant feature. And sometimes it's exacerbated by exercise and activity. So Eliana, who works with us, was well ahead of the curve and has been passionate about seeking guidance from people with lived experience of ME/CFS for many years, long before it was cool to do so, which in turn not only informed our research, but has also taught us such a lot about living with the disease. The top quote came after discussions around preliminary immunological studies, when we invited people with ME in to have a look at the results and see what they took away from them. And they felt that mild, moderate, and severe were almost like two distinct conditions when they looked at the immunological responses. But they were very keen, as the second quote shows, to carry on with the research. At another focus group, just to illustrate how stigmatized living with ME is, we had a table of people with MS. We have disease controls who are people with MS, and they'd contributed to the study. And one man told us his story. He'd been told he had ME/CFS for many years, but his diagnosis was changed to MS. For him, it was a red-letter day, a day of huge relief. At last, he had a recognized illness, albeit one that would likely further negatively impact his life. So what did NICE recommend as the principles of care for people with severe ME/CFS? I know that as a nurse, my principles are usually based on trying to encourage socialization, activity, and rehabilitation. And really, when you approach the person with severe ME/CFS, you have to put all that out of the window. It requires huge empathy and discipline on the part of the healthcare professional who's not used to dealing with this illness. And it does go against every bone in our therapeutic body. NICE recommended regular reviews and energy management and symptom management, including rest and sleep, physical function and mobility, orthostatic intolerance, pain control, medication, we can't give much in the UK, diet, and cognitive behavioral therapy as an adjunct therapy. So if you're living with a chronic disease or with cancer, or with any diabetes, it's a challenge, and cognitive behavioral therapy can be good to address that challenge. We also talked quite a lot about safeguarding, because historically children have been taken away from parents who've been accused of abuse when the disease has been little understood. I think that's getting better, but it's not perfect yet. So what did people with severe ME tell me as when I visited them, and how can that guide our practice? So one lady told me that living with ME is like walking through treacle. I don't know what the Portuguese for treacle is, but it's like walking through mud. Everything just requires an extraordinary effort. So there can be extreme weakness with severely reduced movement and reduced ability to speak or swallow. If you look at the second quote, when I waken, often in the very late morning, I feel no more rested than I did at the end of the day before. Everything's an effort, no matter how long the time asleep. And I don't know how many of you felt like that in the beginning stages of a dose of COVID, but certainly I did. I woke up thinking, oh, have I got to get up? But that's how it is every single day. So this has implications around timing of appointments, there's unrefreshing sleep or hypersomnia, altered sleep pattern, and you have to think about how you're going to communicate, what time of day, when you're going to book your appointments, when you can expect people with severe ME to be able to respond. When someone visits, I have to choose. I can either eat a biscuit and have a cup of tea or listen and respond. I can't do both. Now, obviously, that has implications for us as healthcare professionals. We need to consider language, clarity, tone, volume, and speed of speech. Reading is like trying to listen to the radio when there's so much interference that you can only hear the odd word. When we think about presenting paper documents to people with severe ME/CFS or presenting a computer screen, we need to consider carefully what they're going to be able to absorb on one page. We also need to consider the entire process of the consultation from beginning to end, making sure not to overwhelm the patient with questions. You need to prioritize measures and consider which ones actually benefit the patient and which ones you're doing just because it's interesting to know. One patient said to me, "Would you mind just shining a light on my arm to take blood?" So I'm balancing 12 blood tubes, an iPhone, trying not to let it get in her eyes, but she just couldn't tolerate any light at all. So sometimes the people I see are lying in bed, they've got earphones on to block out any noise, the room is all dark, and when the carer approaches, they approach with ample warning and with a very, very quiet voice. Just gently touching the patient as you approach them to let them know that you're there. A parent of one girl said to me, "Please don't wear freshly washed clothes when you visit because the smell of detergent or softener can worsen her symptoms." Another girl I visit has a tea towel put under her door in the morning because when the gentleman in the flat opposite leaves with his aftershave, it can trigger her for a whole day, just coming under the door. So it's really important. Perfume's gone out of the window, huge economy for my husband. And I think very, very carefully about what I smell of when I go in to see a patient. "I'm so sorry, I know you just asked me to do something, but I can't remember what." And that's typical. You can't ask a patient to do 3 things at once or ask them 3 questions in a sentence because often they'll remember the first one and then you just have to repeat. So it's better to break things down and ask them gently. And again, sometimes I grasp at words, feeling like a toddler learning to speak all over again. We all know what it's like when you can't remember the same word, but this is like every 5th word in a sentence and the most simple of words. And cognitive difficulties limit the person's ability to take in verbal and written comms as well as their ability to communicate with us. Other sequelae of severe ME/CFS, gastrointestinal problems, nausea, constipation, incontinence and bloating, and these can be overwhelming symptoms for the person with severe ME/CFS. Malnutrition is real and not recognized, and I'm sure many of you have heard of the case of Maeve Boothby in the UK, who died of ME/CFS basically because her nutrition was not addressed despite the fact she was in hospital. I've already mentioned the relationship breakdown in families and among friends, and marriages and partnerships are greatly at risk. And even when I go into someone who seems to have such a happy, supportive partner, I'll get an email years later saying, "You won't be surprised to hear that my wife left me." Financial hardship and poverty. People in England love to offer you a cup of tea, but so often a patient will say to me, "Would you like a cup of tea? But I can't offer you milk. I'm sorry. I would have bought milk, but I can't drink it. I don't drink milk. It doesn't agree with me. And I can't afford to buy just milk like that. I go into flats that are covered in mold because the council's doing nothing about it and the patient doesn't have the energy to fight their case." There is real poverty caused by this disease. And of course, the economic burden on the country is huge. Loss of identity and low self-worth is evident. A deep fear of infection. So I always listen really carefully to what the patient would like me to do when I visit. Maybe they want me to take my shoes off. Maybe they want me to wear a mask, and maybe a particular mask. And I'm always very careful to do that. The first thing I do when I go into a house is very openly wash my hands. I make sure the tap makes a lot of noise and that the patient is very, very well aware that I'm taking every precaution. Since COVID, I take a COVID test whenever I go to see a patient, and I let them have the result before I visit. And I think that's very important. And I notice that family caregivers are pushed to the limits of their resilience and beyond. There's very, very little help for these stigmatized people. If you get cancer, people bring you cakes, they bring you flowers, they send you cards. If you get ME/CFS, I'm afraid it's not the same deal. So I think it's really important to be aware of all that. And you can use Maslow's hierarchy of needs, thinking about, the right at the bottom, you're thinking about limiting infections, sensory sensitivities, and then going up to preventing symptom worsenings, being sensitive to their social isolation, recognizing the dignity and value in a person with severe ME. I often look around the room for clues about the people that they used to be. They used to play the guitar, they used to write poetry, they used to love reading, they used to walk, and all that's been stripped away from them. And finding meaning and purpose in the face of uncertainty, often just a visit is enough. Even if you can't do much to change the situation, your being there is a validation of their situation, and so important. I went to Amsterdam recently and visited a mother and a daughter who both had severe ME/CFS. They lay in a downstairs room, the mum and the daughter beside one another. It was darkened. They'd obviously been hugely active at some point, or at least the mum had. There were embroidery pictures and all sorts of stuff going on. And now it was really, really difficult just to talk to them. And even more sadly, the father was also unwell. When I asked the mother of the couple, did they have any dreams of what they might do when they got better, she said, yes, I have a list. And it was the first animation I'd seen. And she got out her list in Dutch, so it meant nothing to me. But she was able to translate, the top of our list is we're going to bake a cake. And that was their dream. So caring for people, I don't know how I'm doing for time. Oh, I better hurry up. Principles of care you all know about. Listening to patients, supporting activity pacing to minimize post-exertional symptom exacerbation, minimizing sensory overload, noise, smell, light, preventing infection. You might have to break up visits in order to produce an individual care plan, and be very aware of benefits, disability aids, allowances, and use the ME charities. They are great. So communicating, listening, taking adequate time to hear and interpret. So often people don't exactly tell you what they really need right away. The GP will speak about the patient at the door who says, and by the way, doctor. And you've got to listen for those signals, and always validating the individual who's so socially isolated. So commitment. It's an ongoing commitment over many years, during which time the condition might worsen and can less often improve. And you should commit to offering first-class healthcare. Whatever you're doing, do it really well as you would for someone dying of cancer. I did hospice nursing. I saw people when I worked at St. Christopher's. The average lifespan was 48 hours. It was one of the first hospices. But even there, often the patients were not as ill as people I see with severe ME/CFS. This is a really serious disease. Breaking up appointments are so often cancelled, people simply aren't up to it. And remember, when you do see the patient, they're at their best. And you might need to support the patient as they embrace treatments that are really very unscientific, and only saying if you think they might be unsafe. And later, when money and hope run out, continue to be there for that patient. Courage. It's the person with ME/CFS who needs the most courage for all the reasons I've said. But the healthcare professional also needs courage and determination to reach out to people with severe ME who might not want to engage, and courage during the encounters, especially when the care plan doesn't quite work out. Compassion. Remembering empathy, respect and dignity, intelligent kindness. Everyone with ME has experienced stigma, and many have tales of experiences that should never have happened. Trust needs to be rebuilt and maintained. There's no place for impatience, but plenty for empathy, respect, and dignity. So how does this pan out in practical terms? Courage enables us to do the right thing for the people we care for, to speak up when we have concerns. It means we have the personal strength and vision to innovate and to embrace new ways of working. And I think we've seen that in the earlier talks this morning. Oh, I'm sorry, was I out of sync with my slides? I do apologize. Anyway, thank you so much to my team who have been stoically behind everything I've done, and to the people who've supported us from the charities and beyond. Those are the references. But most of all, thank you to all the people who've seen me in their homes, welcomed me, shared their challenges, joys, their dreams, and their losses. It's been a real privilege.
Okay, thank you, Caroline, for this very interesting presentation. Any question for Caroline? There? Microphone. No, microphone, we don't listen.
Thank you. I just want to remind you that you wanted to say something about the biobank.
Yes, and thank you to Ella who prepared the slides, by the way. I couldn't have done that, even if I did get them out of sync. We have a biobank of samples. We have too many samples. We would like to distribute samples. There is a charge list, but everything can be negotiated. So please do speak to us if you're interested in taking samples from the biobank for your research. We have samples from over 600 people with ME/CFS, severe ME/CFS, MS, and healthy controls at up to 7 time points. Thank you.
No, there is another question there. And I have also a question.
Yeah, thank you very much for a nice presentation. I'm Rob Hust from Amsterdam, and one of the part of the biobank that we are setting up in Amsterdam, I've been asked to take biopsies from patients who are homebound. Not particularly bedbound yet, but homebound. So all the work that you're doing essentially really prepares for this. But do you think this is feasible from your perspective to take?
Well,
to take
interestingly,
measurements?
Eliana did discuss biopsies with the people at focus groups before I was on board. Generally, people were more keen to give blood, but I think it would be good for you to discuss with Luis and Eliana. I wasn't actually at those focus groups, but the reason we went down the blood and not the muscle biopsy avenue was because that's what the participants asked us to do.
So the blood is, you would say that is relatively feasible
Yes,
to do.
yes, and I know they're doing that in Amsterdam because
Yeah,
that's,
exactly. I know,
yeah,
perfect.
yeah.
Perfect. Yeah, thanks.
Well, Caroline, you talked about one thing I see frequently in my clinic. That's the patients who seems to do not tolerate their own sense. Light, sound, hear, touch, allodynia, of course. And also they are intolerant for many foods and drugs. All for the 5 cents are very badly tolerated by these patients. Do you have any idea about the meaning or about the physiopathology of this? But there is a
No,
very frequent
I see
issue
it
in
all
clinic.
the time, yes. That's why they don't have real milk in the house, because there's intolerance.
Yeah. But
yes.
we do the analysis, and they are not
And they-
intolerant
it doesn't
in the
show
lactoses
anything
and the
like that,
gluten and so on.
I know.
But they don't feel like to eat or drink some. And the drugs, we have a small amount of drugs to treat
Yes,
those
the
patients, and they are intolerant for many of those
Start them on
drugs.
Tiny doses and build up. But Luis will speak, I'm sure, about that. Will you, Luis?
Joan, one question. Okay, Luis, we are going to talk about it, but Joan has a question.
Yes, we actually have a viewing party of people who can't get out of bed in our support group, o Grupo de Apoio Encefalomialgia Long COVID, a WhatsApp group, and they just wanted to congratulate you on the extraordinary talk.
Oh, thank you.
And so they're all
They're
listening.
extraordinary people.
So thank you so much as a team.
Thank you,
Thank you.
Caroline.
Thanks.